Dr. Thomas Kuriakose. He's going to speak on involving clinicians in quality. He's the first Deputy Director of Quality in CMC VELLORE, Professor in another Department of Ophthalmology in CMC VELLORE, pan-ophthalmologist with special expertise in retinal surgeries and more than 40 indexed national and international publications in the field of ophthalmology. He has an eye for everything.
Respected Chairman, sir, and friends. I have to say I really enjoyed Dr. Sunil's lecture. Common sense, which unfortunately is very uncommon, dictates that clinicians should be in the forefront of all quality initiatives. But unfortunately, this is not so. While it is true that it is the enlightened clinicians that push the quality initiative and clinical governance, you cannot generalize that. In fact, the clinicians are the most difficult group to bring into the quality system because they're not familiar with these quality systems because that was never part of their training. At the outset, I have to say that the clinicians don't do this intentionally. They want quality. It's just that they're not used to it. Even me as a clinician and being in charge of the quality initiative in CMC felt that sometimes these standards really are not all that correct, just like many scientific theories, and wondered whether it's really needed. I wonder how many of you have seen this poster which says, "Scientists have proven that bumblebee cannot fly, but the bumblebee does not know this and continues to fly." I sometimes feel that quality standards are something like this. You know, the standards are mentioned, but there is no evidence that the previous existing standards were bad. But this is just implemented. They want us to implement it regardless. All these points and which we'll discuss make roping in clinicians a little more difficult. Now, the first important thing is convincing the clinicians to get into this quality program. Now, each institution has their own problems. Dr. Sunil has his own. I have to say, we in CMC are a much more quieter, docile, not so aggressive group. Of course, we also had the same problem when initially clinicians asked, who are these quality chaps to dictate to us when we, CMC, we have set the standards. So the important thing is to train, to convince these people, you have to tell the clinicians that quality-related issues do kill patients. You will have to tell them how severe the problem is. Hospital errors, is the third most commonest cause of death after cancers and cardiac problems. You have to show the clinicians that there is evidence to show that these quality initiatives improve patient outcome. The other thing clinicians are worried is, are these quality guys coming to police you? This was mentioned before too. So you will have to convince the clinicians that we are in partnership and not trying to police them. Now, to understand, to induce these clinicians into quality initiatives, you also need to understand their mind. Now, having got through these competitive exams and done medicine, the clinicians think they are the cat's whiskers and the thinkers. Now, this can cause problems. And this attitude is made worse if the more senior you become. And the bigger institution, it becomes worse. In fact, that's the reason I think AIIMS has still not got accredited. The clinicians also see themselves as leaders and not followers. So following somebody else's clinical standards is not probably what they like most. They also hate routine protocols. It's almost they think that they're not using their senses. The clinicians, again, need a reason to do things. Unless you give them an explanation for what they're doing, they're unlikely to follow. Just reading out the standards and say, go and do it, I don't think will change them. Then there is the other species of clinicians, so-called senior clinicians you have to address. Now this group does not understand evidence-based medicine. For them, it is all professor-based medicine. That means what the boss says is correct. And this leads to a certain amount of clinical arrogance. In fact, it is this arrogance that also makes them, they don't have the insight to think that there is a possibility they're outdated and that, new systems are needed. Now, being in my position at this age, I can confidently say it is difficult to teach old dogs new tricks. Now, there are some other challenges that one needs to worry about as far as the clinicians are concerned. Before I go into that, again, I have to say, let's be clear here that the clinicians are passionate about making the right diagnosis and giving the right treatment. What they don't realize is that the associated systems that achieve this is also important, and that's where quality comes in and where the quality standards actually come in. Now, the other issue is, as was mentioned, the handwriting. Doctors are really not very well known for their handwriting, and on top of this, now you tell them to write everything in block letters. Well, they're not going to be happy at all. Quality standards, as I mentioned, are new to clinicians. It's not part of MCI curriculum, so they have to relearn this whole thing, and they think they would rather update their clinical skills rather than learn a whole lot of standards. Following protocols, again, the clinicians think it's demeaning them, their individuality, but that's all misplaced thoughts. Of course, following protocols or standards can change working patterns, and change is not always easy. Now, with all this basic information, how do we start addressing these clinicians? My first rule is, unlike what Sunil said, never address all the clinicians together. Divide them. The strategy we followed here was to attack the middle level faculty, not the top. Because this middle level faculty can influence both the seniors and juniors, and in time, they will become the seniors. Give the middle level management the management responsibility which they would otherwise not have had at that stage of their career, and they would enjoy that. In order not to insult the seniors, tell the seniors they are very important clinicians who should not be bothered with these routine stuff. Now, you have to set a thief to catch a thief. You have to make sure that it is clinicians who train the clinicians. If you don't, only they can convince them. If you don't, the standard rhetoric will be, oh, these guys, they have nothing better to do. That's why they are coming in telling us about standards. And you may not be very successful in trying to teach them standards. Education, to me, I think is the most important thing that one requires to induce clinicians to get into quality. Nobody comes to the hospital every day with the intention to kill, but mistakes do occur, and it is these quality standards that will prevent these mistakes, and the clinicians have to be told that. Clinicians also have to be told that quality is more than protocol, and it is the intention behind it that's more important. Again, in teaching setups like this, the clinicians have to be convinced and told that protocols will save their time. Now, as I mentioned previously, clinicians are the best people to train because they also can give clinical examples while they are talking about the various standards. I remember Dr. Vikram Kashyap, who gave us our first introduction to various all these standards. Brilliant teacher who used to give very good clinical examples, and I have to say that's what really convinced me. Audit training. Clinicians often confuse audits and research, and that makes them hesitant to do this. So we'll have to train them to tell them that audits are actually very simple, and you don't require sophisticated statistics for doing that. If possible, start teaching audits at the PG level itself. In fact, we had a little bit of stint of success. The university actually made it mandatory for our PGs to do audits, and that was a great time. You will also have to tell the clinicians how the results of clinical audit can be used for self-improvement and assessment. Now, it would be a great thing if doing clinical audits be part of these whole reaccreditation process of your own degrees, with the MCI or authorities like that. Even the hospitals should make clinical audits part of the job description and give people time to do this. Now, besides training and pushing, there are some carrots also that may induce people to go towards quality. A knowledge about clinical governance or quality initiatives will be good for jobs, especially if you are looking for jobs outside the country. The clinicians, the clinical audit, listed just like your publications on your CV will look great. It, I think, should also be part of quality initiatives done by clinicians should also be part of their appraisal system, and that will improve their compliance. In this era of legal litigations, if the doctors are following standards and show that they are doing audits, that will be their best defense against successful litigations against them. So what is the role of the quality cell in all this? Now, besides the, outside the immediate influence, I think the quality cell should be only educators. They should be facilitators to support the audit and change and ensure that the change is implemented. They should also facilitate library services and lobby with the management to give people time to both update and also do qualitative initiatives. The quality cell should use their data to feedback and encourage clinicians. Of course, there should be mechanisms to deal with poor performance. The quality department should be the institutional memory to encourage the new leadership to carry on the process. The mirrors do two things. When you look at it, it tells you exactly your current position is. It also encourages you to change if you don't like what you see. And it also gives you a feedback as you are changing and brushing up. I think one of the good ways to encourage clinicians to get into clinical quality initiative is to go through this mirror cycle, where after education they have their audits, then look at it, change, again re-audit. This. In closing, I would like to thank the organizers for this opportunity. I did not realize that when we set up this whole quality management system way back in 2007, that this will flourish to this level, and that we will look beyond our own accreditation and quality to look to see whether we can pass this quality system to the outside people. But CMC has always been not about itself and has always strived to give others. And I offer my salutations to the administrators for being so supportive of our quality team to take off in this direction. This national conference is a testimony to the dedication of Shushina, Lallu, Rabi, and the whole quality team, their dedication for the cause. The non-intrusive and tactful manner in which they have handled the clinicians has made a huge difference here. And that is what has really involved our clinicians so well into this quality system. And I wish the quality team all the best, and I hope that they continue to be a blessing for the patients, because finally that's what we are here for. Thank you.